I'm Vas Sadda, and I'm going to spend the next time talking about CIRRUS OCT and OCTA imaging and workflow in this COVID-19 era. And I think it's really an important topic because we're all dealing with the pandemic, and there are implications for how we manage patients. And imaging, I think, is really front and center in a lot of what we do as retina specialists. So I think it's hopefully a good discussion that we'll have. I'm involved in working in a number of different imaging related projects and have worked with Zeiss as well as a number of other imaging companies in this area. So again, my topic is how do we use our OCT and Angioplex, OCT angiography in our clinical practice, and how has this been impacted by COVID-19? And as ophthalmologists, we think about, who are the physicians, who are the frontline workers, essential workers. It's a kind of a common lingo that's used these days. And really, one of the things that I think sometimes our people aren't aware is that as ophthalmologists, we really are on the front line of worker groups who really have a substantial risk for COVID-19. And maybe the best evidence of that is that the first ophthalmologist to really identify COVID-19 as a novel disease was an ophthalmologist in China. And one of the reasons we're at particular risk is that we know that respiratory droplets are the primary mode of transmission. And when we do an ophthalmic exam, especially at the slit lamp, this requires close proximity between our face and the face of the patient, and that really provides an opportunity for spread. We also know that there's good data showing that coronavirus can be present in the tear film. And of course, we may have contact with the tears during examination of our patients, for example, during indentation, scleral depressed ophthalmoscopy. And so because of that, I think all of us have had to implement some modifications in our practice to reduce the risk for our patients as well as our staff. We actually had published an article on this recently in Ophthalmology Retina, talking about some of the changes, particularly with regards to how we approach neovascular AMD patients. And I'll connect these to exactly the implications related to imaging. But we do pre-screening and we adjust our schedule now. So a day prior to a patient's visit, our staff contacts all the patients on the schedule. We review with them whether they've had any symptoms of COVID or exposure to a patient who's known COVID-19 positive, and we'll defer their appointment in that situation unless there's an urgent reason, such as acute vision loss or some other reason why they have to be seen right away. In addition, we've spaced out our clinic, increased the time between appointments, especially if you know there's a patient who's going to need more time, maybe a patient with a retinal degeneration, something of that sort. We'll build that into the schedule. In addition, we have new clinic entry procedures prior to being allowed into the clinic. People undergo a temperature check. We ask them again those screening questions that we asked the day before. Make sure they have a mask, provide them if they don't. And then we also check for proper wear, because I think all of us seen, we see people who are in masks. The masks are sometimes hanging below their nose or their mouth, and that's obviously not very effective. And the patients who fail to pass these screening procedures, we don't let them into our main clinic area. And we've actually created a secondary clinic space sort of detached from this, where patients who don't pass screening but still have urgent needs and need to be seen, they can be directed to. And so we see patients who have a high suspicion of COVID actually in a completely different area compared to our standard clinic patients. In addition, we've obviously increased the spacing between seats. When we have overflow patients, we ask them to wait outside in the car, so we ensure that distancing is maintained. All staff and patients are in masks, and we use surgical or similar masks, and we've indicated to patients that thin fabric masks, like these kind of bandana type of setups, that they're not okay. We have good data now that they're not as effective at reducing respiratory transmission. And if there are going to be extended, long procedures or examinations required for something unusual, then that's when we might use N95 masks. Otherwise, the only reason we don't use them routinely is really they're in short supply, and we're trying to reserve them for when we might need them for these longer types of procedures. And when we're actually examining a patient who's known to be COVID positive, we will use gowns and shields. And we've also re-engineered our workflow a bit. The rooms obviously undergo a very thorough cleaning with bleach and disinfectant between patients. We maintain a single room for the patient throughout the clinic visit. So the technician will work up the patient in one of the exam rooms. Then they'll go out to get their imaging briefly, and then they come back to that same room for the physician exam and also the procedure, like an injection if they need one. So the patient really only exits this room for imaging. In addition, we've implemented larger shields, for example, on our slit lamps. We've actually had UCLA has actually fabricated ours, but you can get these shields. They're commonly available, and you can purchase them from the vendors now. In addition, the OCT can be configured with a shield. This is available for order. You can get one from Zeiss, for example. We even concocted our own kind of a shield. This is one that you can custom build in a few minutes. And this is one of the real, I think, beauties with regards to CIRRUS OCT. It's nice that, you're not facing the patient directly, so you're sort of kind of off axis, easier to shield them and have a more complete shield this way. I think that's been helpful as well. And of course, with the CIRRUS devices, it's also possible to do a remote capture where you can even do it from another room. There's even YouTube videos you can see where you can even set up a screen where you can guide the patient through the process and be in another room. So there are precautions that you can take that certainly that we use to reduce our risk even during the imaging procedure. And imaging is especially vital now. In addition, we have sort of an overriding principle of minimizing exposure. So we reduce our time in the room. We explain that to the patients in advance because already we're pretty fast as retina specialists. When you minimize that even further, you don't want to take away from the patient experience. So we alert them, and they're pretty understanding of that. And so we reduce the time in the room. We review the images outside of the room, and it's good to have these kinds of workstations set up to efficiently do that. And so we also reduce the examination time. I think all of us have already become quite dependent on imaging. OCT really can be a superior tool compared to biomicroscopy for many indications. And that's another way of reducing it. We ask ourselves the question, what are we really trying to get out of this particular exam procedure? Can the imaging provide adequate information? And maybe we can skip it. I think these are all things all of us need to be thinking about. We also do fewer lengthy diagnostics. I mean, clearly there's more time required to do a fluorescein angiogram or an ICG, and we really want to reserve those for when it's really critical for decision making. So I think what we've observed in the pandemic is that it's really increased our use of Angioplex quite a bit. And that's where I think higher OCT scanning speeds of these next generation SD-OCT devices, CIRRUS 6000 is an example, where you get 100,000 A scans per second. That's pretty important now. There's a premium on every little bit trying to shorten the imaging time. I'll talk a bit more about that later, but reducing the chair time, we think, reduces exposure, and I think that's not a trivial consideration now. Another thing I want to highlight when I want to get into a little bit of some specific sort of imaging findings and research that we've tried to translate to our own clinical practices. And I think we've seen that there's been an evolution in clinical practice approaches based on imaging, and that sort of follows a bigger trend, I think, in ophthalmology. We're evolving to this more personalized medicine approach, and I want to talk a bit more about that. And here's a typical patient, a 75-year-old woman, no symptoms, was referred in by the referring optometrist, I think in this case, good vision, 20/25, had some cataracts, but the optometrist obviously could see these drusen as well. But we can see that there are these large drusen present in both eyes, I will say, had the same finding. And here's another patient that we saw in clinic. This patient, you can see, has pigmentary alterations as well, and they manifest as these areas of intraretinal hyperreflective foci lying above the large drusenoid PEDs in this case. This patient was also asymptomatic and had good vision. And here's a third case, and I'll really tackle this a little bit later on in the presentation, but I'll bring it up here, of another patient who had a large drusen on exam and had this sort of more shallow, regular RP elevation that you can see here. And this patient was also asymptomatic and doing well. These are all pretty typical of the types of intermediate AMD patients that we see in clinical practice. And all of these on our current staging systems for AMD, we call these as intermediate AMD. And the question I would like to pose today is, should all of these cases be monitored the same way? And if not, what is the appropriate interval for monitoring such a patient? Now, if we look to the American Academy of Ophthalmology guidance, we'll find that if you look for intermediate AMD, they recommend monitoring every 6 to 18 months. That's a pretty big interval. And so the real question is, again, with this focus on personalized medicine, is can we use OCT biomarkers to individualize our approach to these intermediate AMD patients? And I think the answer is yes. And I think that most of us would agree that OCT has really replaced color photography as our key imaging modality in clinical practice. It's not that color is not important, it's just that OCT is the workhorse. And we know that features of intermediate AMD, such as drusen, pigment migration, these are well seen on OCT. We've identified a number of OCT risk factors for AMD progression. This is a paper from almost a decade ago where we first sort of went down this path. This was a study where we identified individual drusen And then we followed which of these large drusen went on to develop atrophy or neovascularization. And we identified that there were some, and this was over 500 lesions that we tracked in this way over a long period of time. And basically, we observed that two of the really striking factors were something I've already highlighted, these sort of intraretinal hyperreflective foci, which we now know in many cases are due to RP migration. And even when we teach our fellows about this or residents about this risk factor, we say, boy, these RPE cells must be so unhappy that they left the monolayer seeking greener pastures in the retina. So it kind of makes sense that that's an eye that might be in trouble. But again, we have good data to support that now. But we also identify that these drusen that have these sort of dark spots in them, these hyporeflective cores within the drusen, those also seem to be associated with greater risk. And through this nice work from Anna Tan and Christine Curcia that we collaborated on, they were able to identify that the histologic correlate of this are these sort of calcific nodules that may be present in these drusen. And that may also be a late stage event before these eyes progress to atrophy or neovascularization. And in fact, with regards to this whole issue of intraretinal hyperreflective foci, we know that's an important precursor event that occurs before the development of type 3 neovascularization or RAP lesions. There's a paper that we collaborated on with a number of other groups in studying this evolution. And it kind of makes sense, right? These RPE cells, they go into the retina, they're near the deep capillary plexus. We're going to talk about that more with OCT angiography, but they stimulate presumably the deep capillary plexus with the VEGF that they release to yield this type of proliferation. So to me, it really fits together very nicely, not very surprising that this could be an important precursor. And there's other things in this original paper. We also noted that we could see a thin choroid potentially be a risk factor for progression to advanced AMD, either neovascularization or atrophy. That's also not surprising because one of the things that we know about this thin choroid is that these patients who have a thin choroid commonly also have subretinal drusenoid deposits. That's sort of the preferred term now, but before we'd call these reticular pseudodrusen. SDD or subretinal drusenoid deposits is more of an OCT term. Reticular pseudodrusen I look at as more of a term we use to describe the finding on autofluorescence imaging, but you see them quite well on OCT. You see that there's these little deposits that are located on the inner surface of the RPE band. So here are these little deposits. Sometimes they form this cone-shaped kind of configuration, but sometimes they can be just a subtle elevation just above the RPE. So it's also an extracellular deposit like regular drusen, but instead of being below the RPE, it's above the RPE. And this has been a huge topic of interest recently in our field because they seem to be an important risk factor for developing advanced complications. I think that, yes, you can use autofluorescence and even you can see them on the IR image that you get with your OCT acquisition, but they're really, I think, beautifully illustrated in the en face imaging. The nice thing with CIRRUS OCT is you have all these preset slabs. I don't know how many of y'all use them, but I use them extensively because I think they're a quick way of looking and getting an idea of if there's pathology present. And we're all trying to be very efficient in our assessment and evaluation of patients. And I find that to be a very nice tool because even on this little thumbnail kind of image, you can sort of see them, but I think it's apparent there's an abnormality there. Sometimes people say, well, they may not be present in the 6x6 field, but we can get larger field OCTs. This happens to be with the Plex Elite, but the CIRRUS 6000 can do a big 12x12 scan, and you can see it really displays the extent of these pseudodrusen. And said again, you don't have to do much work. You can just go to the EZ sort of map, and that's where they're roughly located, and they really come out. And I think it's an important thing that we look for. I actually can just see them just scrolling through the B scans is what I try to do, but you can look at them, look for them that way. As I said, they're pretty easy to spot, but the en face view I think is very helpful, and just go to the en face analysis on the machine or in the software, and you can visualize them in this way. Another thing with some of the advanced analyses that are available on the device, one of the other things that we use very commonly that our photographers just put out as a report, so I don't have to really do much work with it, it's just one of the reports that we can visualize, is the advanced RP analysis report. What that does is it segments out the RPE, but also where the RPE should be, sort of the RPE fit, if you will. If there wasn't a drusen, wasn't an elevation, where would the RPE be? If you then create sort of surface maps of the RPE and sort of the RPE fit, and you subtract them, the subtraction basically gives you the drusen. And now you can compute drusen volumes. And I think that's really where the field has gone to, is looking at drusen from a volumetric standpoint. This is really a lot of nice work that was done by Phil Rosenfeld's group and Bascom Palmer. And they showed that in fact these measurements could be highly reproducible. And we studied them in the reading center as well at Doheny. And we observed that not only were they reproducible, but there was, if you actually had human graders go and painfully manually segment all these boundaries, there actually was very good agreement between the algorithm, really high interclass correlation coefficients you can see between the drusen volume obtained by the machine and the human graders. So we find this to be a very powerful tool. And you might say, okay, well, you're saying it's a powerful tool, like why do I care about drusen volume? I would argue that it is really something that's coming to the forefront now. It's already being used as a potential quantitative information or biomarker in early intervention trials. For example, Robin Geimer in this nice nanosecond kind of laser trial, they were applying that to these eyes with drusen. Again, we kind of think that the laser to drusen story is sort of over. And I guess with conventional laser, I would say it kind of is over because that was evaluated by the CAPT trial and PTAMD. But this new nanosecond laser that are evaluating this, interesting thing was when you treated one eye, the drusen even seemed to go away in the other eye, which is kind of really interesting. But in any event, it's very easy to see on the drusen volume analyses these change in drusen over time. So we may be called upon as retina specialists to collect this kind of data in our clinical trials. Now, we've been very interested in using this to perhaps further our genetic studies in collaboration with Dwight Stambolian and Jonathan Haynes and Peggy Parachik-Vance in Miami. We've been involved in these Amish eye study, and we've been using drusen volumes as a more quantitative biomarker of the burden of AMD in the eye. And this may facilitate our discovery of new genetic associations of AMD. So that's pretty exciting, I think. But also, drusen volume may have prognostic value. This is something that Phil Rosenfeld first highlighted. And actually, in collaboration with Phil and also with David Boyer, we did a study where we had 90 patients with intermediate AMD, and we had volume CIRRUS OCT scans, and we computed drusen volumes. And we followed these patients over 2 years, and we looked for progression to late AMD. And it turned out that the patients who were most likely to progress, they had higher drusen volumes. In fact, Phil Rosenfeld sort of pre-specified, a priori suggested a cut point of 0.03 cubic millimeters, because the machine gives you this output of the volume. In fact, if we draw that line here, actually it was really good at separating patients at risk and not at risk. So we really liked that cutoff point that Phil had suggested. So then the question becomes, okay, I've reviewed all these different risk factors, like, well, how do you put this all together? How do I take this to my practice and use this? And so we did a study where, again, we want to first replicate all these individual risk factors that I just highlighted that came out from different studies. And so this was a retrospective analysis that we published. Again, these are all patients who had CIRRUS OCT, so we could do the drusen volume computation. And the bottom line was we graded them not only for drusen volume, but we also graded for the presence of these hyperreflective cores, hyperreflective foci in the intraretinal hyperreflective foci, and also these subretinal drusenoid deposits. And we also computed a drusen volume, and we looked specifically for a drusen volume greater than 0.03 within the central 3 millimeters. So the machine gives you these sort of outputs, and we were focused on the central 3 millimeters. So central drusen are probably most important, kind of makes sense. And then we looked at the follow-up OCTs to see who progressed to atrophy or progressed to nevascularization. And then we correlated those baseline risk factors against this progression to advanced AMD. And what did we find? Again, we found all of those 4 risk factors were correlated with the risk for progression. The hyperreflective foci, that was the most predictive. And actually, I will tell you, every study shows that. And so that was kind of exciting, especially they were predictive for GA development. So we said, like, okay, well, that's great. But still, how do you turn this into something you can use in clinical practice? And we said, well, why don't we do something simple? We borrowed from Rick Ferris's work with AREDS. I think a lot of us use this in the clinic. I mean, that's what we've been teaching our residents and fellows, that you see a new patient with AMD, intermediate AMD, you just determine, do they have large drusen and pigment changes, and you give a point for each, and you do that in both eyes, and you can get a patient score. And Rick Ferris showed that that correlated with your risk for progression to late AMD over 5 years in that case, because that was AREDS data. And so we wanted to do the same thing with our data. We said, okay, what if you, unfortunately we have 4 factors now, so it's not just 2, so you have 4 here, but you can do the same thing. You get 1 point for each, so you can get a max score of 8 rather than 4. And some people kind of complain like, oh, 8, that's too much. So we said, okay, divide by 2. You can still divide by 2 and make it 4 points. And basically, it really maps out very well to your risk of progression. You can see if you have a lot of points, you have a super high risk of progression to advanced AMD over a 2-year period. And so we found that this is a potentially very useful way of very quickly in clinic risk stratifying your patients. Of course, you might say, well, that's one study. I mean, do you really believe just one study? And I would say, no, you want to have it replicated. And so we took advantage of the Harbor trial. This was a study that we were fortunate that Genentech gave us this data to be able to do this analysis. And basically, I'm not going to go through the Harbor study design because I think most people are quite familiar with it. Our focus here anyways is actually on the fellow eyes. So, right, so the study eyes all had CNV. They were treated in the Harbor trial. We're interested in the fellow eyes, and we specifically looked at the fellow eyes that didn't have atrophy or CNV. So when you start with all the subjects, you start to exclude the ones that have CNV or atrophy in the fellow eye or missing follow-up data. We ended up with 501 subjects, basically. And so we had 2 years of follow-up data on 501 subjects, essentially intermediate AMD, or at least they had AMD and the fellow eye had and CNV. So that was great. And basically, we found the same thing. We found that these same risk factors predicted the risk to progression. Again, intraretinal hyperreflective foci was the biggest one, followed by the hyperreflective cores, and then STD, and then finally the drusen volume. I would say, by the way, nobody should be surprised that drusen volume is kind of the weakest one because, you know, as I said, like the drusen volumes, they can go up over time as patients' AMD gets worse, but then they start to go away. We know that drusen disappear, and then usually something bad happens. So I think that's one of the things that's sort of a confounder in drusen volume. That's why it's not as strong. But again, these risk factors all come out again, and you can do the same type of, you can, you know, do them according to those categories that we identified in the previous based on counting the number of risk factors. And again, it seems to work really well at predicting progression to late AMD, whether it's atrophy, we call CIRRUS now with the new CAM classification, or macular nevascularization. All right, so again, still, like maybe it's not clear, how do you translate that to practice? What do I do? Well, I obtain my OCT scans, and I look at the entire volume for the presence of hyperreflective foci, those hypoflective drusen cores and STD, and I have my photographer, they generate the advanced RP analysis drusen volume map, and I just do that quick risk assessment to those different categories, and I adjust my monitoring interval based on the risk assessment. So Academy gave us a wide berth, huge follow-up interval. Well, this is how we personalize it to get the very high-risk patients in much sooner because they have a much higher probability of progression. So that's what I do, and something for you to think about. As I said, I think there's a lot of data to support this thought process, at least. I'd like to use the last portion of my talk to talk a little bit, switching from structural OCT to OCT angiography and how we use Angioplex in clinical practice. Just with regards to the Angioplex software and the OMAG, or the optical microangiography algorithm that's used on the CIRRUS device, it's based on what we call complex analysis, which means that you include both the phase as well as the amplitude information, which I think can be of help. You have to have good tracking, and fortunately the device has that, because you have to acquire repeated scans in the same location, and you compare sort of the differences in phase or amplitude between the scans to get the flow signal. So only those things that are changing light up as red on the flow overlay. And then you, of course, can take the flow from the B scans and then convert it into the on-phos view, which most of us are used to looking at. Although I will tell you, I find looking at the E-scan flow image is vitally important to interpret the on-phos Angioplex map. And of course, you can get a very high resolution 3x3 scan, or you can go to larger fields with 6x6 or 8x8, and you go even larger. We'll talk about in a moment with the CIRRUS 6000. One of the challenges as you go bigger is that you can have a reduction in resolution because you don't have as many pixels. This is just to compare the 3x3 versus 8x8. So it really depends on your application, what you're trying to learn. If you're trying to look at a fine MacTel lesion, you might go to a 3x3, but you might go to a larger field if you're looking for larger swaths of non-perfusion. Sometimes, we don't like to send the patient necessarily back for repeat imaging. So what do we do as our default? Because I'll say in one of our offices, we pretty much get an Angioplex for most patients along with their structural OCT. And we do it because that's one of the nice advantages of this device and the Angioplex software is it's fast. And so it doesn't add a lot of time, but we also don't have the time to do like multiple different scan patterns. And so we have the photographers use a 6x6 as our best compromise. As I mentioned, now we have faster devices with the CIRRUS 6000, so you can do really big OCTs as well as OCT-A scans, and that's pretty huge in terms of being able to do things faster. This is an example of the really larger raster scan 12mm scan you can get, which I think is useful when you're trying to understand vitreous relationships. That's nice, but especially nice is to be able to do big wide field OCTs with a single acquisition. That can be useful when you're looking for areas of non-perfusion. I think we'd all agree with that. And of course, also now we can do sort of like these high definition kind of scans, which, I think it kind of minimizes a little bit. I already talked about how you go to a bigger scan and you sacrifice some of the resolution. Well, you can get some of that back by doing these HD kind of scans. So I'd encourage you to think about that. As I said, in our practice, we sort of use this as the compromise size because, the photographer can't read my mind necessarily about what I want to know about that patient. And I find that that does really well. I mean, it's very rare that I have to send the patient back for some other scan when they do that. Just to show you that you can do that with the larger scan patterns as well. Now, there are other things. Let's say you say, okay, that's good that I get to that wider field now, but maybe that's not good enough. You want to go even wider to look at these even more peripheral areas of non-perfusion. If you want to do that without sacrificing image resolution, unfortunately, you have to kind of do a montage. This is a nice image from Phil Rosenfeld of a diabetic patient that you can appreciate. You can see all these areas of non-perfusion. Of course, if you go to 12 by 12, then that's even faster to do the montage, but it still takes time to do a montage. So I will have to confess to you in our own clinical practice, I mean, if we're collecting something maybe for a publication or some specific interest, maybe we'll do a montage. Most of the times we try to really be efficient, and from a time perspective, there are other tricks that we came up with. One of my former fellows, Akuhita Uji, had published this nice paper of adding a 20 diopter lens in a trial frame before obtaining your scans, and then you can extend the field substantially. One of my subsequent fellows, Takeo Hirano, he actually adapted this to using this for OCT angiography and published a nice paper showing that you can get a substantially higher field by using what we call extended field imaging. So something to think about. Well, again, you lose resolution, obviously, but you may not need that when your main objective is to look for NV or look for areas of non-perfusion. You can see it gives you a substantially greater area compared to the standard acquisition. So it doesn't take more time, it just gives you a bigger field. But your photographers do have to get used to using it if they're going to go that route. So I don't mean to say that it's super easy, but it's something that they can learn to do. Okay, so another advantage of OCT angiography, of course, is that it's depth resolve, which means that unlike fluorescein angiography, where we have pretty limited depth resolution, we can separate the superficial capillary plexus, or SCP, from the deeper vascular beds. There are actually probably 3 layers in a large portion of the macula, but most of the devices, they sort of divide things into superficial versus deep, which is sufficient for most of the things that we're interested in. But really what I want to highlight is you can really see that these are different layers because the morphology is really quite different. You have this sort of vortex kind of configuration where the capillaries feed into the veins that really drain from the DCP level. And the nice thing with the Angioplex is that we get not only a sort of the full thickness map, but we get all these maps. You get this vitreoretinal interface map that you can see up here, which I'll highlight as super useful for looking for neovascularization. But you get the different layers of the retina, as well as an avascular retina map. You don't expect to see vessels there. So when the photographer gives me this report and I see stuff there, I'm kind of worried. At least makes me double check. I mean, is there a segmentation there? Is there something else? Or is there real pathology? So it's really nice to have these pre-built segmentation maps that I think when you're busy in clinic, I don't have time to go, quite frankly, and adjust borders and pull out different slabs. I need to have these preset stuff. My photographer, they do the OCT angiogram, and they gave me this report, and I'm able to look through that very quickly. This is sort of what we get in our system. And I can see, I mean, you can see that there's something wrong here, I think, from a mile away. And obviously, this patient obviously has a critical vascular membrane. One thing I would strongly advise, though, is if you want to interpret your OCT angiograms appropriately, you really need to be able to see the structural image to make sure there's not just a bright object that the light is bouncing off of and creating an artificial flow signal. And of course, seeing the B scan itself is helpful to really confirm that there's flow. But again, I will admit, I only go back and do all those things now in a case where I have some uncertainty. A lot of cases, I can just look at the report and feel pretty confident about what's happening. All right, so I just want to briefly touch upon some major clinical applications of OCT angiography and Angioplex that we use in our clinical practice. And I'll start first with looking at retinal neovascularization. And Phil Rosenfeld was kind enough to share this nice proliferative diabetic retinopathy case with me. There's obviously a patient, you can tell they have pretty bad diabetic retinopathy here. You see the neovascularization on the color photograph. And of course, you see the leakage on fluorescein angiography in this case. And again, to highlight that area, we can scan that area certainly with OCT angiography, and you can beautifully see, you can actually see the vascular network. The VRI slab is the best slab for that because it picks up this region, and you can see the nevascularization. You can see that there is flow there, the en face image. So this patient was treated with PRP, as it turns out, and actually, despite PRP, it seemed like the nevascular membrane wasn't getting any smaller. Maybe actually was getting bigger. In fact, they were followed along and it was getting bigger yet. And that's what's cool is with OCT angiography, you can actually get precise measurements because you don't have all this leakage obscuring our view, which can be very valuable when we're trying to figure out, well, what should I do for this patient? And of course, they were growing despite PRP. And so this is just a montage of multiple scans, just highlighting other areas of nevascularization. But, one of the things that I've talked about with Phil before is, maybe we can use a single NV when you're using anti-VEGF therapy to kind of give you a sense of what's happening in the eye. So you don't necessarily have to scan every single NV. But in any event, I think tracking at least one of the major lesions along is very helpful. These are at least 3 lesions in this case. This patient was given an anti-VEGF injection. You can see what a dramatic effect it had only a month later in terms of reduction in flow in this lesion. A second injection was done. And some of us wonder, well, how many injections should we give this patient? That's where I think following them with OCT angiography can be a potential tool to help us. And you can see that this patient was observed, no injection was given, and things look pretty stable over several months now. We're at 14 weeks here. And then eventually, though, you can spot that maybe a little something has changed here. Is that real regrowth? Well, if you wait longer in this area, I think it would really become manifest. But this patient was actually treated for that, and you can see that after the injection, it does disappear. So that really was an early nubbin of nevascularization. So the hope is we can use OCT angiography. That's kind of what we've been doing in cases where we're going to manage with anti-VEGF therapy. I think this is certainly a potential very valuable tool. And again, there's another little nubbin. You're wondering, is that really real? This present here? I don't know. Maybe watch the patient longer, and then you can see that things actually get larger if you watch this patient. And then obviously this patient was ultimately treated at that point. Okay, but there's other major applications, I think, of OCT angiography. One of them is identifying non-perfusion. I will tell you again, we published one of the first reports. This was way back in the early days, but this is over 5 years ago when we had published on using OCT angiography. This is a patient with vein occlusion. This was just really to highlight how much more detail we see compared to fluorescein angiography. Really, you can see the demarcation between the perfused and non-perfused areas in this patient with a retinal vein occlusion. And of course, the nice thing is we can identify these areas of non-perfusion, even spot some of the microaneurysms using OCT angiography, and you can even map out sort of the vessel densities, if you will, from these subjects. Here's another patient where you can see areas of IRMA, I think very beautifully illustrated on OCT angiography. Another patient with more advanced non-perfusion associated with proliferative retinopathy and diabetic macular edema. And one of the concerns in this particular patient who had some persistent cystoid change was, this persisted despite multiple anti-VEGF therapy. And I remember my fellow asking, well, maybe it's just from ischemia, maybe it's just cystoid degeneration. But when you sort of overlay the thickness map to the vessel density, the OCT image, which you can easily do on the device, you can see that most of the thickening is actually where the microaneurysms and the like are, not where the non-perfusion is. And so this patient actually was treated with steroids and the edema resolved. So I find that to be very valuable. I don't do fluorescein angiography anymore to look for macular non-perfusion. I think, if you want to look at the far periphery, I think you need to do ultra-wide field imaging. And I think fluorescein angiography is extremely valuable there. But for just macular non-perfusion assessment, I think the Angioplex does a phenomenal job with that. Okay, but there's other conditions that I think OCT angiography is very valuable for. One of them is MACTEL. Another condition, we used to do a dye-based angiography all the time, but now this is another dice case from Phil. I chose it because he's actually color-coded this, but you can see even without color coding, you can see in the deeper layers, there's this retinal vascular abnormality present. This is another, same case with MACTEL. Again, you can see the telangiectasia all around the foveal avascular zone, but especially temporally, pretty common of MACTEL. Again, I don't think this fluorescein, we need to do them anymore when we're able to identify them and make the diagnosis so easily with OCT angiography, as well as look for complications like subretinal nevascularization. But just another illustration of that. The telangiectasia being limited to that deeper layer, I think, is very helpful for making the diagnosis. And again, as I said, even though you can corroborate with fluorescein angiography, I actually feel that we don't really need to be doing that. I think OCT angiography is perfectly good for making this determination. Another area where OCT angiography has been huge is in monitoring of macular neovascularization. One of the questions people ask is, do you need a fluorescein before starting therapy for a patient you suspect has wet AMD? And I would say, I don't think so for the vast majority of cases, and especially in the COVID time. I think that this really is pretty big, and I think we feel comfortable if we can do OCT angiography and we have evidence of exudation. I think that's good for me. And here's just an example of a large neovascular membrane, readily apparent. Again, if I'm going to be in a reading center and I'm going to be trying to measure these things, okay, I'm going to go back, check all the segmentation. But the nice thing about having all these pre-filled slabs is, if you just want to know, is there neovascularization or not, the report that my photographer generates is plenty good enough for me to make that assessment, because I've gotten all the different slabs going through the retina. Just another example, again, you can see this from a mile away. I showed this case earlier where, again, it's very easy to identify the neovascular lesion in these cases. And again, if you have any doubt, you can look at the B scan. But some of these cases, it's just very clear without doing much effort at all. Just more examples, not to bore you with too many examples of neovascularization, some difficult cases even. And then you can have more challenging cases where you're wondering, again, this is where I think it's worthwhile looking at the B scan, also the structural image. You wonder, is that something? Well, you see that the flow is all coming kind of from deeper to the retina, and the structural image highlights this area, and you can see the illumination actually here that's impacting the structural OCT image. This is an area of atrophy, obviously. Now, this is a case that I showed earlier, or similar to a case that I showed earlier, of a patient who has this shallow regular RP elevation. You're wondering, is that neovascularization? But the patient has no exudation, maybe asymptomatic in this case. This is the right eye of this patient. They already are known to have neovascular AMD in the fellow eye. And of course, do OCT angiography in this case, and it becomes very apparent that they have a membrane present. And I think that can be invaluable in making these diagnoses of this sort of non-exudative neovascularization. Again, we find that for these sort of type 1 lesions, this type of a slab, if you really want to refine it and maximize your view of the lesion and really make it pretty, you can go to the device or the software and manipulate it. Again, as I said, from being a research study, we absolutely do that. In busy clinic, I'm not doing that majority of the time, but you can do it. And again, it's not a trivial thing to identify, because a number of investigators have shown that if you follow these patients with these types of non-exudative neovascularization over time, they can develop exudation. Now, some people have questioned, should you treat them when they're asymptomatic? And I would just highlight that there's no evidence so far to support doing that. So I don't, but that's something that people are looking at. But what I do is that I monitor these people more closely. I think if you have this, I might start seeing them back in 2 months. And if nothing's happening, maybe I'll go to 3. But again, we are worried because these patients are at high risk for conversion to exudation. And we know earlier treatment for neovascularization is associated with better visual outcomes. So that's what I like to do. And this is just Phil's nice paper showing that there is a increased proportion of patients who progress to exudation if they have this type of non-exudative neovascularization. We also find OCTA to be very helpful in excluding choroidal neovascularization in the setting of patients with pachychoroid disease. You see these little RP elevations. You're wondering, is it just central CIRRUS causing the fluid? Could there be neovascularization complicating it? And it's incredibly valuable. Here's just a case example of a patient of mine who had kind of chronic CSR, was observed in the past for several months, and this episode actually resolved. And then they came back 11 years later, actually. Now they're 61, and we could see that there was this shallow regular RP elevation that should be apparent here. And in fact, OCT angiography confirmed the presence of neovascularization in this case, which ultimately triggered the anti-VEGF therapy. Now, of course, this can be tricky in the CSCR patients because sometimes both the CSC component as well as the neovascularization may be contributing to the fluid and you don't know. But again, at least highlights the consideration for anti-VEGF therapy in such a case. Lastly, and I'll close my presentation with this, is I think, and again, I will admit, first of all, I'm going to give a caveat because I have a huge bias because most of my research nowadays is involved in the choriocapillaris. But I think one of the greatest contributions of OCT angiography is in our ability to start to evaluate the choriocapillaris in these eyes. David Saraf showed, for example, in eyes with placoid maculopathies, like AMPI and the like, that you could see these areas of choriocapillaris loss, and they could actually, in some cases, improve as the patient was treated, which I think is important, because now we have a better handle on the pathophysiology of diseases. And of course, this may be a valuable tool for us to even distinguish different white dot syndromes. For example, in MUDES, we've seen, this is one of papers from Davis and Phil, but there have been several papers that have shown in MUDES the choriocapillaris is relatively uninvolved. So I think that this is just an example from their case where the choriocapillaris looks quite clean. And so I think that could be a very valuable tool in differential diagnosis. And of course, my research is focused on is in choriocapillaris and AMD. And again, Giovanni Strenghi nicely showed that the choriocapillaris in eyes that manifest atrophy can be different, that in patients with AMD, the choriocapillaris loss tends to be more patchy, whereas in patients with Stargardt's, it's very severe, that you don't find any choriocapillaris at all. And Giovanni speculates that it's why patients with AMD in the late phase of the ICG, the atrophy stains, it's hyperfluorescent, whereas it remains dark in Stargardt's patients. It may reflect the severity of the choriocapillaris loss. So I think we're just scratching the surface. We think the choriocapillaris may be an invaluable tool at predicting the progression of AMD, but that research is still forthcoming. So to summarize, I do strongly believe that the efficient use of imaging technology, in particular, I've highlighted, of course, structural OCT and OCT angiography with CIRRUS Angioplex, but I think that it really is critical in this COVID-19 era. Having a fast device ergonomic software interface is particularly important now, and you need to have these clinically relevant presets and defaults. I think you need to be able to be efficient in clinic. I've also highlighted how a new understanding of some structural OCT biomarkers allows us to take a more personalized, individualized approach to AMD management, and something I think for at least to be considered. And I do think that OCT angiography, we're still scratching the surface. I think the applications will continue to expand, and my own viewpoint is that this really is already an essential tool in clinical practice. And with that, I thank you very much for your attention. I look forward to taking questions. Thank you.